All right, so let's talk about some restrictive pulmonary diseases. Before we get started, like I always do, I just wanted to thank you so much for the really nice comments you guys have been leaving, the new subscriptions. And if you don't mind, if you haven't subscribed yet, I would really appreciate that. It really does help get the word out about the YouTube channel. So thank you so much for all of that. Let's go ahead and get started with our restrictive pulmonary diseases. So this is a group of diseases that obviously cause restriction in the expansion of the lungs. So these patients are going to have trouble getting air in, but not trouble getting air out. And it's caused from a number of factors that we're going to go over: fibrotic changes, lung scarring, and things like that. I'll break down probably the two most important, which is sarcoidosis and idiopathic pulmonary fibrosis, and then we'll quickly go through the pneumoconiosis and towards the end. So let's go ahead and get started with sarcoidosis first. So sarcoidosis, it's an idiopathic multi-system inflammatory disease. It manifests as non-caseating granulomas. You'll most commonly see these granulomas in the lungs and the intrathoracic lymph nodes. Now, as far as the patho, it's all about the T cells. T cells play a central role. You have this exaggerated T cell response, and it leads to this excessive cellular immune reaction that's going to cause your inflammation and granuloma formation. So basically, the immune system has gone into overdrive, and it's causing all of this inflammation, like I said, granulomas throughout the whole body, and it'll cause a lot of the clinical manifestations that we'll go over a little bit later. Now, risk factors, there's two things you need to know because this is who's going to be in your vignette. It's going to be an African American female. That will be who's going to be in your vignette. I promise you. If you have a vignette for sarcoidosis, it'll be an African American female. Now, African American, 3 to 4 times more common to be seen in this race. And then females, there's a slight predominance in females with sarcoidosis. So in the vignette, again, you will absolutely see an African American female. That's the question you're going to get on sarcoidosis. So you need to remember these little things because it's going to help you out in the questions to kind of differentiate some other causes. Now, clinical manifestations, well, remember, this is a systemic disease. It can affect anywhere in the body, and therefore there's a lot of possible clinical manifestations, but I'm going to focus on the common ones, the unique ones that the boards like to test on. So the first thing you need to know, the patient could be completely asymptomatic. So half of the patients with sarcoidosis, it's actually going to be an incidental finding on a routine chest radiograph. So it doesn't always mean that they're going to have symptoms, but if they do, pulmonary complaints will be the ones that you'll see most common. So pulmonary complaints, non-productive cough is a big one. Dyspnea on exertion, chest pain. These aren't very specific, but these are the ones you'll commonly see. Now, the unique ones, the ones that are probably going to be in the vignette, are your dermatologic findings. So first one, erythema nodosum. Now, I'm sure we've all heard erythema nodosum. It's not specific to sarcoidosis. It's those painful nodules that are common on the anterior surface of the lower extremities. And like I said, it's non-specific because you can find it in strep infection, it can be caused from medications, ulcerative colitis. But the key to erythema nodosum regarding sarcoidosis is if you see it combined with migratory polyarthralgias and fever and bilateral lymphadenopathy. If you see this, this is known as Lofgren syndrome. So again, Lofgren syndrome is erythema nodosum, migratory polyarthralgias with fever, and bilateral hilar lymphadenopathy. If you see this, this is so specific to sarcoidosis that you don't even need a biopsy to confirm the diagnosis. This is enough to make the diagnosis. So Lofgren syndrome is very important to know. So erythema nodosum by itself isn't very specific to sarcoidosis. It can be found in a number of other things, but combined in this triad here, very specific. So Lofgren syndrome, again, is those three components. Now, a more specific dermatologic finding, in fact, this is pathognomonic for sarcoidosis, is something known as lupus pernio. So this is what it looks like. It's these indurated plaques, violaceous discoloration, primarily found in the face, the nose, cheeks, lips, sometimes the ears too, and more common in African American patients with sarcoidosis. So that's lupus pernio, very specific to sarcoidosis. It's pathognomonic for the disease. Lymphadenopathy. You may find bilateral hilar lymphadenopathy. It's this enlargement of the lymph nodes of the pulmonary hyla, classic finding of sarcoidosis. And then don't forget restrictive cardiomyopathy. So this is one of your infiltrated diseases that can cause restrictive cardiomyopathy due to the granuloma deposition in the myocardium. Remember, amyloidosis is your most common cause of restrictive, but you very well may see sarcoidosis as another one of the potential causes. Now, moving on to diagnosis, so there's no definitive test for sarcoidosis. Obviously, biopsy is a very good test, but there's nothing definitive in the diagnostic workup. What you're looking for is a combination of a few different things. So the first thing, you want to make sure you have your clinical manifestations that match up with sarcoidosis and your radiographic manifestations, which we'll go over in a minute. You want to make sure you've excluded other diseases that can present in a similar way, like tuberculosis. And then finally, you want to have your detection of a non-caseating granuloma on biopsy. That's generally what you're looking for, those three things there. You don't need to memorize that, but I just want you to know that when you're actually out there treating patients, these are the things you'll look for to make the diagnosis. Now, starting with your chest x-ray, you're going to see something known as bilateral hilar lymphadenopathy. So about 50% of affected patients with sarcoidosis are going to have bilateral hilar lymphadenopathy as the first expression of sarcoidosis. So if we take a look here, it's the big fluffy stuff at the center of the chest x-ray you can see here and here. It's just this enlargement of the lymph nodes of the pulmonary hilum. So fluffy stuff here and here, center of the chest, that's what you're looking for. Now on labs, this is a big one. So increased ACE levels. So your serum angiotensin converting enzyme, ACE levels elevated in about 75% of patients with sarcoidosis. Now what you need to know this for your boards. You need to know this because this will be on the vignette. But we need to know in real life, this test actually has pretty poor sensitivity. There's a lot of false negatives. It's really not a great diagnostic test, but it's going to be on your vignette. So you definitely need to know increased ACE levels with sarcoidosis. Now, pulmonary function testing, as we went over, this is a restrictive disease, so you're going to see restrictive pattern. Your PFTs are going to show that decreased FEV1 FVC ratio. I'm sorry, not decreased, I apologize. They're going to show that FEV1 FVC ratio, which is going to be normal or increased. Again, FEV1 FVC ratio normal or increased because this is a restrictive pattern. Again, these patients have no trouble getting air out. They just have getting trouble air in. It's so restrictive pattern. The way that I used to remember that restrictive was had a normal FEV1 FVC ratio, normal increased, was R in restrictive stands for raises the ratio or remains the same, or raises the ratio increased. And then obstructive, oppress the ratio, they keep it down. So FEV1 FVC is going to be decreased in obstructive, and in restrictive it's going to either be increased or remain the same. That's the way that I used to remember that for your pulmonary function test. And then on your biopsy, so your biopsy, non-caseating granuloma is what you're looking for. So you can perform a biopsy anywhere there's a lesion. So it can be a cutaneous lesion, it can be a palpable lymph node. You don't necessarily have to be going for the lungs. And again, what you're looking for is that non-caseating granuloma. That's your characteristic finding in the biopsy. Now moving on to treatment. So treatment is very easy. Steroids. That's really all you need to know. Oral corticosteroids are first line. That's it. Not every patient's going to need treatment. A good number of patients with sarcoidosis are going to undergo spontaneous remission or have a benign clinical course. But if they ask for medication, it's going to be steroids. Now, how do you remember all the things you need to know for sarcoidosis? You remember that your ACE levels are super high. So ACE levels super high. A stands for African American, because remember it's 3 to 4 times more common in African American patients. C stands for cough, dry cough. E stands for erythema nodosum. L stands for lupus pernio. Remember that's pathognomonic for sarcoidosis. S stands for steroids, your first line treatment. And then H stands for hilar lymphadenopathy. Remember your bilateral hilar lymphadenopathy. That is sarcoidosis. This is really all you need to know right here. Don't go crazy on that. All right, now let's move on to idiopathic pulmonary fibrosis. So this is another one of the diseases. We don't know why it's caused. So it's a rare form of fibrotic lung disease, no known etiology. You have this progressive scarring of the lungs over the course of several years. And again, no specific cause known, but there are a few important risk factors you need to know. And this is quite different than sarcoidosis. So first, cigarette smoking. Majority of patients with pulmonary fibrosis are going to have a history of cigarette smoking. Second one, again, this is what makes it much different than sarcoidosis. It's going to be more common in males than females, opposite of sarcoidosis, which was more common in females. And then finally, age. This is going to be seen in older patients, most commonly seen in the 6th and 7th decades of life. It's rare to see idiopathic pulmonary fibrosis in patients less than 50. So on a vignette, you're looking for an older male that smokes. That will be in your vignette for pulmonary fibrosis, very likely. Clinical manifestations, nothing really specific here. Dyspnea on exertion, non-productive cough with this insidious onset over the span of a few months. Nothing really that you could look at and say, okay, this is pulmonary fibrosis. This could really be any pulmonary condition with these types of findings. Physical exam, again, really not that specific either. You may have something known as bibasilar crackles, which can be absent early on in the disease. And just so you know, because sometimes you'll see these terms and you never know actually what they mean. So all bibasilar means, it means the bases of both lungs. So bi stands for bilateral, and then basilar at the bases. So bibasilar, so at the bottom of both of the lungs, you're going to hear crackles. And then clubbing. So remember, just like in any other chronic hypoxemic state, you can have clubbing of the fingers, that's what that looks like there. So that's another finding you may have in pulmonary fibrosis. So again, nothing really very specific here. And as you'll see as we go on, there's not very many things that are specific in pulmonary fibrosis, which normally means you probably won't get a question on it because it's hard to ask a question about something that doesn't have very specific findings. That's why this is also difficult to diagnose in some cases. So moving on to our actual diagnosis, the first thing that you're going to do with these patients, again, is a pulmonary function test. And remember, pulmonary function test is going to be a restrictive pattern. So normal or increased FEV1 FVC ratio because of that restrictive pattern. If you do a chest x-ray, you may see increased reticular markings. So again, this is not very specific. It can be seen in other interstitial lung diseases and even in heart failure. Where your diagnosis gets a little bit better, a little bit more specific, is with your CT. So CT should be obtained in all patients with suspected pulmonary fibrosis. It's significantly more sensitive and specific for the diagnosis compared to chest x-ray. It's really essential in the diagnostic workup. So the characteristic findings, CT findings of pulmonary fibrosis, are going to include three things. First one is known as something called honeycombing. So this is this peripheral basilar predominant opacities. The reason it's called honeycombing, let's take a look here, is because you have these cysts spread throughout the lung field. They're all different sizes. They're normally pretty small, about 3 to 10 millimeters. And when they're clustered together like they are here, they look like honeycombing. So just like you have a honeycomb here, it looks like all these little holes you can see here kind of looks like this, right? You know, somewhat at least. So that's why it's called honeycombing. It's all those little cysts that are clustered together from all the fibrotic changes. The other thing you may see, something known as traction bronchiectasis, bronchiolectasis. So this is just due to the damage of the bronchioles. You have these distorted, abnormally dilated bronchioles. And then finally, something known as bilateral ground glass opacities. So all this is this hazy increased lung opacity, and it's just caused from the scarring and the fibrotic changes in the lungs. It can be seen in any of the interstitial lung diseases, sarcoidosis, but it's a bit more prominent in pulmonary fibrosis. So those are the three things you're looking for on a CT: honeycombing, traction bronchiectasis, and the bilateral ground glass opacities. Now, biopsy, you're going to be looking for these alternating areas of normal lung next to fibrotic changes, next to honeycombing. So you have fibrotic changes of varying ages or levels of severity. And then next to that, you can have normal lung. And then next to that, you have honeycombing. That's the hallmark biopsy findings in idiopathic pulmonary fibrosis, a combination of these different levels of changes in the lungs. Now, treatment, there's no cure for idiopathic pulmonary fibrosis outside of a lung transplant. Most of the measures taken, most of the treatment options for this are going to be supportive. So the first things that you want to do, you want to make sure they stop smoking. Yeah, and you're likely going to get them started on supplemental oxygen. Almost all patients with pulmonary fibrosis will eventually require oxygen. Actually, let me rephrase that. All patients with pulmonary fibrosis are going to eventually require oxygen. Initially, it'll just be with exertion, but eventually it'll progress to the point where they're going to be on it pretty much continuously. So this will be something that all patients are going to need. Now, medications. There's a lot of drugs they've tried with no clear benefit. They've tried anticoagulants, phosphodiesterase inhibitors. The only ones you need to know, and really the only one that have ever shown any benefit, are two medications. They are antifibrotic agents. They're known as nintedanib and pirfenidone. So these are the only two medications you need to know, and the only two meds that are really used that have shown any they can slow the disease progression. They're by no means a cure, really, but they're the only thing that we have outside of a lung transplant. So these are the two antifibrotic agents that can slow disease progression, and really the only medications that you need to know for pulmonary fibrosis. The other thing, again, like I said before, is a lung transplant, which is the only definitive option. So going through everything we went over for pulmonary fibrosis, it's just very non-specific. Like I said, it's unlikely you're going to get a question on it. The presentation is non-specific. Most of the imaging findings are generally non-specific. There's not much in the way of treatment, so I wouldn't waste too much time here. Most of these restrictive disorders, unfortunately, they're not very high yield. There's just a few things you need to know about each one, and this is especially one that's not very important. Let's move on to the last thing. So these are your pneumoconioses, or occupational lung diseases. So these are a group of interstitial lung diseases that are caused by the inhalation of certain dusts, minerals, and they lead to these fibrotic changes in the lungs. Now, I keep saying this, but again, this is another one. It's pretty low yield. You really need to only focus on the risk factors for each one. The question you're going to get, really all you're going to need to know is their job description. So they're going to describe their job. Maybe they're working in the textile industry. They have this chronic cough, and you just need to know that they're going to list a bunch of different things like co-worker pneumoconiosis, silicosis, byssinosis. You just need to know that it's byssinosis because of the fact that they worked in a textile factory. So really what you should focus on, and what I'll go over, is the kind of occupations that expose these patients to these different occupational lung diseases, and then a couple other things that I feel like are somewhat important as we go through it. The first trick that I have for you to know what you need to know here is this. So if the job they do is working down low, the nodule, the pulmonary nodule, is going to be up high. If the job they do is up high, the nodule is going to be down low. Now, what do I mean by this? So the example. So coal workers' pneumoconiosis, for example, they work down low. They work in coal mines in the earth. So the nodule is going to be the opposite. The pulmonary nodule you'll find is predominantly located in the upper lobe of the lungs. And luckily, this tip works out for any of the ones that have a predilection for a certain part of the lung. So any of the ones that we'll say normally found in the lower lobes, they're going to have a job where they work up high. So this little thing that I came up with to memorize it, this actually works out really well. So we'll go through it and I'll kind of show you on each one. So that's the first tip you need to know. If they work up high, they work in an attic, they work in the ceiling, the nodule is going to be found down low. If they work in the ground or underground, the nodule is going to be found up high. It's the opposite. So that's the first tip. Now let's actually go through the actual different diseases. The first one, coal workers' pneumoconiosis. Obviously, they've inhaled coal dust particles, and the nodules, remember, they work deep down in coal mines. They work in the ground, deep down. So where are their nodules going to be found? In the upper lobes. The opposite. This works. It's great. It's a nice thing because you won't forget it for the exam. And then the other thing that I think you need to know, the only other thing, is there's something known as Kaplan syndrome. All this is this a combination of coal workers' pneumoconiosis and rheumatoid arthritis. Is this very high yield? No, but maybe if your preceptor asks you this, you'd sound really smart. Maybe you'll get a question on it, probably not, but just so you're aware of this. So those are really the only three things I think you need to know for this. Obviously, it's inhalation of coal dust particles. Nodules, because they work deep in the ground, are going to be found in the upper lobes. And then something known as Kaplan syndrome is a combo of this with rheumatoid arthritis. That's all you need to know for that one. All right, let's move on to Byssinosis, I don't know however you want to pronounce it. All you need to know about this, the risk factor, is going to be somebody that works in the textile industry where they have this cotton mill dust exposure. So this is more common in people who work in the textile industry where they produce cotton fabrics. That's what a textile industry is. I didn't really know that either. But textile industry or textile factories are where cotton fabrics are made and turned into yarn and things like that. So because of this cotton dust exposure, they're at risk for something known as byssinosis. So that's all you need to know for that one, really. Asbestosis, a few things you need to know here. So this is caused from an inhalation of asbestos fibers, which lead to this diffuse pulmonary fibrosis. Now, the people that are going to be at risk are people that are renovating old buildings, working with insulation, like up in attics, working in shipyards, installation of production of tiles and shingles on the roof. In the U.S., asbestos has been limited since the 1970s. The only places that it's still being permitted to be used here in the U.S. is in brake pads in cars, gaskets, roofing products, and some fireproof clothing. But any buildings or insulation, things like that, it's no longer allowed to be used in. But the reason I put old buildings is because obviously if it was built prior to that, asbestos can still be found in the insulation and other parts of that. Now, chest x-ray. where do you think you're going to find the nodules in these patients? Remember I said roofing tiles and shingles. They work with insulation in buildings and attics. So all of those things are up high. Where do you think the nodules or the plaques are going to be? They're going to be down low. So they're going to have these pleural plaques. They're going to be most commonly found in the lower lobes. So the plaques in the parietal pleura, generally in the lower lung zones, is where you're going to find that. Another thing you need to know on chest x-ray, there's something known as a shaggy heart sign. You have this indistinct heart border. So the interstitial and pleural involvement may cause this hazy ground glass appearance to the chest x-ray, and it can blur the diaphragm and the heart border, which causes this shaggy heart sign. So let's take a look what that actually looks like. So on a normal chest x-ray, you can see this well-defined heart border here and here. When you look here, you have all these little opacities. They're more prominent on the left side, and that's all from asbestosis. So it obscures the cardiac border, and it leads to that shaggy heart sign because you don't have a nicely defined heart border here and here. It's kind of like indistinct. It kind of ends here, maybe here. So that's your shaggy heart sign, and you can see that in asbestosis. And then, of course, you have an increased risk of bronchiogenic carcinoma, particularly in smokers, because there's this synergistic effect with smoking and people with asbestosis. Non-smokers with asbestos exposure, the odds for developing lung cancer are about 1.7 compared to smokers with asbestos exposure. That risk goes up to about 9 times as high. So smokers and asbestos, there is a very high synergistic effect between the two, and there's a very big risk for bronchiogenic carcinoma. So that is asbestosis. Let's move on. Just a couple more here to go over, and then we will wrap it up. So this one's known as Berylliosis, I believe is how you pronounce it. This is a chronic beryllium disease, and it is a granulomatous disease caused by exposure to beryllium. So beryllium it's lighter than aluminum. It's 6 times stronger than steel. And for that reason, it's used in a lot of specific industries. The aerospace, aeronautics industry, for that reason. It's used in a lot of electronics. So people who manufacture electronics, these are all the risk factors. The defense industry, dental appliances, all because of the factors of beryllium, how strong it is, how light it is. These are some of the industries you'll see it in. Now, the two most important are the aeronautics industry, aerospace, and electronics. These are the ones you'll commonly see in the vignette. Those are the more common occupations or the risk factors that are going to put people at a risk for berylliosis. And that's really all you need to know for that one, is just make sure you remember aerospace, electronics, they work in these areas here, very high risk of this, and that'll probably be on your vignette. Silicosis. So a few things you need to know with this. So silicosis, inhalation of silicone dioxide. Now, risk factors. Any job that involves processing or breaking up silica containing rock or ores, you have a potential risk for silicosis. So that's going to be people working with granite, quartz, sandblasting, slate, masonry work. If it mentions a rock, it mentions that granite, quartz, masonry, anything that mentions a rock in the vignette, you should be thinking silicosis. Chest x-ray. So 2 things that you need to know on a chest x-ray finding that come up. Now, these patients work with stones, rocks, minerals. Where do you normally find those things? Is it up in the sky or is it down on the ground? It's on the ground, so it's down low, meaning where are you going to find their nodules? If they work down low, it's going to be found in the upper lobes. Nodules are going to be found in the upper lobes because they work down low. One other thing that you need to know, there's something called eggshell calcifications. It's this thin layer of calcification around the hilar lymph nodes that look like eggshells on chest x-ray. It's not only seen in silicosis, you can also see it in co-workers pneumoconiosis, long-standing sarcoidosis, but it's most commonly seen in silicosis. So if you're going to see eggshell calcifications on a vignette, they're likely going to be referring to silicosis. So remember that as well. Now, all you need to know for silicosis, remember in the vignette, patient's going to work with rocks like granite, quartz, sandblasting, X-ray, look for those upper lobe nodules and eggshell calcifications. All right, so that's all you really need to know. Don't waste your time digging any deeper than that. This isn't high yield enough to really go far into all of the treatment options and everything. And the thing is, for all of these, really the treatments are pretty basic. It's pretty much just going to be steroids or supportive measures. There's really not enough to know here. I would just focus on the couple things I mentioned with the x-ray, and then focus on where do these people work that they were exposed to it. Now, I don't know if you like stories, but I have a way to remember all of the different pneumoconioses, and it is a story. So let's get ready for story time. If this helps, I'm happy. If it doesn't, I'm sorry, but I try to come up with a way for you to remember it in the form of a story. So let's do a story here. So Sylvia was tough as a rock. But this tough exterior would shatter like an eggshell every time she begrudgingly had to go to work. So Sylvia stands for silicosis, which, remember, silicosis, anyone that works with a rock is exposed to silicosis. So Sylvia, silicosis, was tough as a rock. Silicosis risk factors, occupational exposure to granite, slate, sandblasting. But this tough exterior would shatter like an eggshell, because remember, eggshell calcifications on those hilar lymph nodes. Every day she begrudgingly had to go to work. Sylvia longed for the day she could say bye, so byssinosis, to the textile factory. Remember, byssinosis, increased risk for textile industry workers she worked at. So she longed for the day she could say bye to the textile factory she worked at. Her dream was to one day build space shuttles, so each night when she got home from work, she would bury Berylliosis, her head in books about aerospace and electronics. Remember, Berylliosis, increased risk for individuals working in aerospace and electronics. For now, this was just a dream, and she would have to do her best, asbestosis, to get through the long days at the broken down, poorly insulated old building she worked at. Remember, asbestosis, commonly found, or asbestos is commonly found in insulation, repairing, renovating old buildings. So that's the story I have for you. I don't know if it's going to help, but hopefully it will, and hopefully you'll get Berylliosis, and then all of a sudden you'll say Berylliosis, bury, what did she bury her head in books about? And you'll remember aerospace and electronics. Hopefully that works, and hopefully it helps. So that's all I got for you on that. Let's do 5 quick questions, and then we will be done. So first question. 45-year-old African-American female presents to the office today for a persistent, non-productive cough she has had for the last 5 months. On exam, you note violaceous plaques on her nose and cheeks. Bilateral hilar lymphadenopathy is visualized on chest x-ray. First-line medication for the likely diagnosis in this patient. Gave you all your keys there to know that that is sarcoidosis, and sarcoidosis first-line treatment is going to be oral corticosteroids. So remember, she had lupus pernio, she had that bilateral hilar lymphadenopathy, she fit the criteria, African-American female, all pointing to sarcoidosis. Question 2, a 66-year-old male presents to the office with a history of a non-productive cough. He works for a construction company that restores and renovates old buildings. On chest x-ray, bilateral pleural plaques are noted in the lower lobes. What diagnosis should be suspected in this patient? So the diagnosis that should be suspected is asbestosis. So pleural plaques in the lower lobes, works in the construction business, repairing and renovating old buildings, which is one of the risk factors for exposure to asbestos. So remember, works in a construction company, renovates those old buildings high up, and then we found on x-ray he had those plaques noted in the lower lobes, and remember, asbestosis, those plaques. All right, question 3. A patient with sarcoidosis presents with erythema nodosum, bilateral hilar lymphadenopathy, and polyarthralgias with fever. This syndrome is known as Lofgren syndrome. Question 4. A patient with co-workers pneumoconiosis would likely have nodules in what part of the lung? So remember, they're working down low, so those nodules are going to be in the upper lobes of the lung. And then question 5, what medication are used? What medication is used in patients with idiopathic pulmonary fibrosis to slow progression of the disease? So remember, there's really only 2 medications you're going to be using in these patients that have proven benefit to slow the progression, and that's going to be pirfenidone and nintedanib. Those are the only 2 medications that have shown any benefit in this disease. All right, so that is your restrictive pulmonary diseases. I hope that was helpful. As always, please leave me a comment if it's helping, and please subscribe if you haven't already. And thank you so much for everything. Good luck on your PANCE or PANRE, your EORs, and good luck in PA school.